Hi there. This is the second and last part of tuberculosis. In this video, we will be seeing a treatment of tuberculosis. Now let's go back some period of time. Let's say we have a patient who has got symptoms and signs of tuberculosis, such as cough for more than 2 weeks, along with that fever, weight loss, etc. This patient, if he had lived in 1800s, this was a period where they did not have any treatment for tuberculosis at all. In 1882, Robert Koch discovered that Mycobacterium tuberculosis is the causative agent for tuberculosis. If this patient lived in 1800s, he would have been sent to a sanatorium. TB sanatorium is a place where all the patients with tuberculosis were sent to, and as they did not have any proper medications for tuberculosis, these TB patients were given nutritious food, good air, good water, and good nursing, etc. Some of these patients might live if they have good immunity. Most of them might die if they have got poor immunity against tuberculosis. If the same patient lived in 1900, remember in 1928, Sir Alexander Fleming had discovered antibiotics for which he had received Nobel Prize. So if this patient lived in 1928, this patient will receive single drugs or monotherapy drugs. So during those periods, different antibiotics was tested to see if these antibiotics can cure a patient with tuberculosis. As the time went by, newer antibiotics were discovered, but later on it was found that certain antibiotics had the property to cure a case of tuberculosis, but the problem was that the efficacy was not that very good. Later on, when scientists, when they made a combination of drugs and gave it to patients, they found that this combination of drugs gave a better results than monotherapy against tuberculosis. Now let's fast forward to 1990s. This was a time we had different antibiotics which worked against tuberculosis, and these patients were admitted in hospitals in order to give the treatment with antibiotics. Most of the antibiotics, when combined together and given, the patient had to take it for long duration of time, that is months to years. This was very problematic both for the doctors and hospitals as well as for the patients. In India, a famous study was conducted in Chengalpet, that is in Chennai or Madras. This is known as the Madras trial. From the study, it was found that certain group of drugs had a very good action against Mycobacterium, and these drugs can be given to the patient from the home itself. The patient need not come to the hospital or get admitted in the hospital in order to take this drug. This finding was so popular that even the WHO started recommending this regimen to all the member countries. This regimen is called as DOTS therapy, or directly observed treatment short course. Now what is DOTS? DOTS is a therapy in which a cocktail of drug is given to patients of tuberculosis. So a patient taking anti-TB drugs will be directly observed by a person called as DOTS provider or a supervisor. He will make sure that the patient has got good compliance for these drugs. After the launch of DOTS, the duration of treatment against tuberculosis has decreased drastically. Previously, patients with tuberculosis had to take these drugs for many months to years, but after the introduction of DOTS, this reduced to 6 months to 1 year. In India too, DOTS was launched, that was in 1992, when the National Health Program Against Tuberculosis name was revised into RNTCP, or Revised National Tuberculosis Control Program. So in order to treat a case of tuberculosis, there are different drugs available such as isoniazid, rifampicin, pyrazinamide, ethambutol, streptomycin, etc. These are called as the first line drugs for tuberculosis. There are also many other classes of drugs which can be used in order to treat a case of tuberculosis. In DOTS, patients with tuberculosis are categorized into two groups, category 1 and category 2. Category 1 is those cases who are new cases. That means any new case of sputum smear positive, sputum smear negative, and extrapulmonary tuberculosis is categorized into category 1. Patients in category 2 are those patients who are previously treated. That is, any patient who is a smear positive relapse, smear positive failure, smear positive treatment after default. TB relapse patient is a patient who took anti-TB treatment previously and he had completed the course, but after some months or years, he started to show again symptoms of tuberculosis. These patients are called as relapse of tuberculosis. A failure case is a case who was started on anti-TB drugs, category 1, and at the end of the course, he was still found to be smear positive. This is a case who did not respond to tuberculosis drugs at all. Defaulter is a patient who was started on anti-TB drug for few months, but after some months he himself stopped the drugs because of any of his personal reasons, and he did not continue the drug. If the patient has a very poor compliance against anti-TB drugs given to him, that too for 2 or more than 2 months, that patient is labeled as a defaulter. Any patient who has got tuberculosis will be put into either of these two categories. Now, why do we have these two categories? This is because the drugs given to category 1 patients and drugs given to category 2 patients, that is relapse failure or defaulters, is different. So category 2 patients require more number of drugs for a longer duration of period. We categorize the duration of drugs into intensive phase and continuation phase. Intensive phase is a phase we give 3 or 4 or 5 drugs together, and these drugs kill most of the mycobacterium in the person's body. But still there will be some mycobacterium left which are known as persisters. There will be dormant mycobacterium which doesn't rapidly multiply. These persisters will pose a problem for this patient in later life. Sometimes this patient can become a failure case if you are not taking care of these persisters. So for this we have something called as continuation phase. In continuation phase we give lesser number of anti-TB drugs for some period of time. In the case of category 1 patient, in the intensive phase we give HRZE, that is isoniazid, rifampicin, pyrazinamide and ethambutol, and this is given for 2 months. After 2 months, the patient will be shifted to continuation phase, in which 4 HR, that is 4 months of isoniazid and rifampicin are given. If the patient is category 2, that patient will be given 2 months of HRZES and 1 month of HRZE. S is streptomycin. All other drugs are given orally except streptomycin. Streptomycin is given as injectable. After 3 months of intensive phase, this patient will be put on continuation phase. In continuation phase, these patients will get 5 months of HRE, that is isoniazid, rifampicin and ethambutol. You can see that all these drug has got a subscript of 3 written on it. This means that these TB patients will get all these drugs on a thrice weekly manner. This is called as intermittent regimen. So altogether, category 1 patients receive drugs for at least 6 months duration, and category 2 patients receive drugs for at least 8 months duration. So you see, these patients has to take drugs for a long period of time. So this patient has to be directly observed. Along with that, they should be followed up. This patient will also be asked to check their sputum samples every now and then to make sure there is sputum conversion from positive smear to negative smear. In the case of category 1, after we test his sputum in the beginning, we'll start him on treatment, and after 2 months of treatment, that is at the end of intensive phase, this patient's sputum will be tested again. If his sputum is found to be negative, he will be started on continuation phase, and after that his sputum will be tested repeatedly on 4th and 6th months. If the same patient, after starting with intensive phase of category 1 treatment, after 2 months we test him for sputum, and if it is found to be still positive, then we continue intensive phase for 1 more month, then after that we will continue with continuation phase. If this patient's sputum is still positive in 5th month, then that patient will be considered as failure. In the case of category 2, when after we start anti-TB drugs, we test the sputum again after 3 months, that is after at the end of intensive phase. If this test turn out to be negative, we will start the continuation phase and repeat the sputum testing at 5 months, 6 months and at the end of completion of treatment. If the category 2 patient has still got sputum smear positive at the end of intensive phase, then we will continue the intensive phase for 1 more month, and then only we will start the continuation phase. And after that, if this patient still has got positive sputum smear, then this patient's sputum will be sent for culture and drug sensitivity in order to find out if the patient has got MDR or XDR tuberculosis. So in daily regimen also it is almost the same. That is, we have 2 categories. Here also for category 1 we start with intensive phase 2 months of HRZE, and after that we start with continuation phase where we give 4 months of HRE. In the previously treated or category 2 patients, we start with intensive phase, that is 2 months of HRZES and then 1 month of HRZE, and after that we give 5 months of HRE. So from this you can see that there are three changes. First one is that here we give these drugs on a daily basis. There in intermittent regimen we had given patients these drugs on thrice weekly basis. Second change is that the dose of all these drugs are lesser compared to the same drugs given in intermittent regimen. And finally the third change is that all the drugs given are the same as that of intermittent regimen, except we give ethambutol also in the continuation phase of category 1 patients. You can also see that even the duration of treatment in the daily regimen is the same as that of intermittent regimen. Next, what is the dosage of these drugs? The dosage of these drugs depend upon the weight of the patient. Here in daily regimen we give something called as fixed dose combination. The difference between fixed dose combination and separate pills is that as we are giving here a cocktail of drug, that is 4 or 5 drugs together, if it is separate pill we had to give 5 different tablets on a daily basis to this patient, whereas in fixed drug combination or fixed dose combination we combine all 5 of these different drugs together into one single pill and give that to this patient. So the compliance of taking the pills will be better when we give FDC or fixed dose combination drugs. The dosage of anti-TB drug depend upon the weight of the patient. As already told you, we have got intensive phase and continuation phase. In the intensive phase, one drug consists of isoniatic acid 75 mg, rifampicin 150, pyrazinamide 400 and ethambutol 275 mg. And in the continuation phase, one single drug consists of 75 mg of isoniatic acid, rifampicin 150 mg and 275 mg of ethambutol. Streptomycin is given separately as injection. Depending upon the weight, we increase or increase the dose of anti-TB drugs given to this patient. So if a patient has got weight of 25 to 39 kg, this patient will get 2 tablets in the intensive phase and 2 tablets in the continuation phase. In case of category 2, we give injection streptomycin of 0.5 grams. If this patient has got weight of 40 to 54 kg, this patient will get 3 tablets in intensive phase, 3 tablets in continuation phase and 0.75 gram of streptomycin injection. So likewise, as the age increases, the number of tablets also or the dosage also increases. This is the same method for pediatric cases also, that is depending upon the weight the number of tablets are increased. But for pediatric TB drugs the FTC is different from the adults, that is the dosage is lesser compared to the adult FTCs. In a case of pediatric TB, the drug given in the intensive phase consists of one tablet which contains 50 mg of isoniatic acid, 75 mg of rifampicin and 150 mg of pyrazinamide and another separate tablet of ethambutol 100 mg. In the continuation phase, there will be a single tablet of isoniatic acid 50 mg, rifampicin 75 mg and ethambutol 100 mg. So a child TB case of 4 to 7 kg body weight will get one tablet each from HRZ and E in the intensive phase, and during continuation phase one tablet of HRE. If it is a case of category 2, injection streptomycin is given 100 grams. Similarly, as the weight increases, we increase the number of tablets given to this pediatric cases. Suppose the child is obese and the child weight is 30 to 39 kg. This child will get 2 tablets of HRE plus 2 adult tablets also in the intensive phase. Similarly, in the continuation phase also 2 pediatric tablets of HRE plus 2 adult tablets and injection streptomycin of 500 if this is a case of category 2. So this is how we increase the number of tablets given according to the weight band in pediatric as well as adult case of tuberculosis. There can be patients in whom we cannot give some of these drugs, that is there can be contraindications against these drugs. So there is another regimen called as Nondots regimen. This regimen is given to those patients who has got adverse reactions to rifampicin and or pyrazinamide. Along with that, those patients who refuse to take DOTS therapy. Non-DOTS 1 regimen is given for sputum positive pulmonary seriously ill and extrapulmonary seriously ill patients. Here the regimen is 2 She plus 10 He, that is 2 months of streptomycin, isoniatic acid and ethambutol plus 10 months of isoniatic acid and ethambutol. Non-DOTS regimen 2 is given for smear negative pulmonary not seriously ill patients and extrapulmonary not seriously ill patients. Here we just give 12 months of He, that is isoniatic acid and ethambutol. The dose is different, that is dose given here is 300 mg of isoniatic acid, 800 mg of ethambutol and 750 mg of streptomycin. Whenever we start these anti-TB drugs, remember that this patient has to take these drugs for a long period of time. So they have to be properly motivated in order to make sure that they have a good compliance for these drugs. So for that reason, we give certain treatment-related information to these patients, in which things like importance of DOTS therapy, role of rest, special diet and isolation, cough hygiene and sputum disposal, HIV counseling and testing, diabetes screening and control, proper adherence to follow-up schedule, making sure that patient knows about the adverse reaction to these drugs, quitting smoking, quitting alcoholism, importance of screening for contacts as well as children less than 6 years for TB. These are the informations which can be told to each and every patient with tuberculosis, not to make sure that we have a very good outcome for the treatment for tuberculosis. Next is drug-resistant tuberculosis. Here we will be discussing about two separate drug resistance, that is multi-drug resistance tuberculosis and extensive drug resistance tuberculosis. Any patients who shows resistance to both isoniazid and rifampicin drugs is known as a case of multi-drug resistant tuberculosis. Any patient who has got resistance towards isoniazid, rifampicin, resistance to any of the fluoroquinolones, and at least one of the second-line injectables like kanamycin, capreomycin. If all these resistance is present, then that patient is known as extensive drug resistance tuberculosis. So treatment given to these two classes, that is MDR-TB and XDR-TB, is different. Let's see what are the causes for drug resistance tuberculosis. Drug resistance can be primary or secondary. Primary drug resistance case is a case who never in their life took any anti-TB drugs. Right now in India, the prevalence of primary drug resistance is just 2.2%, but the prevalence of secondary drug resistance is very high, that is 15%. So secondary drug resistance means those patients who had previously taken anti-TB drugs. So this is an alarming situation, that is increasing resistance in those patients who are taking anti-TB drugs. So these patients should be immediately referred to higher laboratory in order to test for drug resistance by different tests like culture and drug sensitivity test, gene expert or CB-NAT machine, and these patients should be started treatment as soon as possible so that they don't spread this drug resistance to others also. The main cause for drug resistance is inadequate treatment of tuberculosis patients. Now let's look at the treatment for multi-drug resistant tuberculosis. Treatment for the MDR-TB is available only at certain centers. These drugs are available at DOTS plus site. Just like the treatment we discussed for drug sensitive TB, here also we have got two phases, that is intensive phase and continuation phase. The duration of intensive phase is 6 to 9 months and the duration of continuation phase is 18 months. Drugs given in the intensive phase include kanamycin, levofloxacin, ethionamide, pyrazinamide, ethambutol and cycloserine. And drugs given during the continuation phase include levofloxacin, ethionamide, cycloserine and ethambutol. If some of these drugs are contraindicated or not available, we have certain reserved drugs which can be given in a case of multi-drug resistant tuberculosis. This include PAS or para-aminosalicylic acid, capreomycin, moxifloxacin, and the latest drug which has been added is bedaquiline. Now let's look at the treatment regimen for XDR-TB or extensive drug resistant TB. Here the duration of intensive phase is 6 to 12 months and the continuation phase duration is 18 months. During the intensive phase, the drugs given include capreomycin, PAS, moxifloxacin, high dose of isoniazid, clofazimine, linezolide, amoxiclav or amoxicillin plus clavulanic acid. The drugs given during the continuation phase include PAS, moxifloxacin, high dose of isoniazid, clofazimine, linezolide and amoxiclav. The reserved drugs for XDR-TB include clarithromycin, thioacetazone, etc. All these cases of tuberculosis, initially when after they get diagnosed with tuberculosis, the first drug is started by the medical officer or the doctor, then they are sent home and they can be followed up by a DOTS provider or the health worker in order to make sure that they complete the whole course of anti-TB drugs. In case of MDR-TB or XDR-TB, these patients are initially admitted in drug resistant TB centers or DOTS plus site, and after some period of time they are sent home and asked to continue the treatment. Before we start treatment for MDR-TB or XDR-TB, this patient has to be properly evaluated. These patients are given lot of drugs, that too in high doses. These drugs can lead to lot of adverse reaction as well as organ damages. So in order to make sure that it is detected as early as possible, initially all these cases are evaluated by taking a detailed history, checking their weight, height, doing blood tests such as complete blood count, blood sugar, liver function test, renal function test, thyroid test, serum electrolytes, HIV. Along with that, urine routine, pregnancy test, chest X-ray and ECG is also done for pre-treatment evaluation for these cases. There is no contraindication for starting anti-TB drugs, both for pregnancy and lactating women. In fact, if they don't take the drugs properly, there is a risk that this TB can be transmitted to the fetus or the newborn child. The drug which should not be given during pregnancy is streptomycin, because this can cause ototoxicity in fetus. During lactation, anti-TB drugs can be given. Along with that, breastfeeding should also be continued. Children born to TB positive mother should take BCG vaccination. Along with that, isonic acid prophylaxis is given for at least 6 months at a dose of 10 mg per kilogram. Mother should be advised that she need to follow the cough etiquette and also proper disposal of sputum. Any patient taking anti-TB drugs containing isonic acid should take vitamin B6 or pyridoxine also along with that, because isonic acid can lead to peripheral neuropathy. There is a close association between tuberculosis and HIV. HIV destroys the immune system of the body, which accelerates the TB infection. In those patients who has got HIV, there is a high chance that this patient can get primary infection or reactivation of latent TB or recurrence of TB infection. TB in HIV positive patients can be cured if it is diagnosed early and proper treatment is given. Therefore, all TB patients should be tested for HIV. Similarly, all HIV patients should be referred to a sputum microscopy center in order to screen for tuberculosis. In patients whose CD4 count is dropping, there is a high chance of TB infection. So in order to prevent TB infection, we can start this patient with isonic acid preventive therapy for at least 9 months duration. Similar to HIV and TB, there is also close association between tuberculosis and diabetes. The risk of tuberculosis is 2 to 3 times higher in diabetes patients than non-diabetes patient, and patient with TB and diabetes has a high risk of death during treatment and also relapse after treatment. If the blood sugar levels are not properly controlled, the treatment for tuberculosis will have an adverse outcome. These are the reason why we have screening for diabetes for all the tuberculosis cases. So any patient with tuberculosis should be screened for diabetes mellitus. If found positive, their blood sugar levels should be appropriately managed with medications. And after that, all these patients should have regular checkup of blood sugar levels. Finally, the vaccination against tuberculosis, that is BCG. BCG is a vaccine which was introduced with the claim that it can prevent tuberculosis, but later on researchers proved that BCG cannot prevent tuberculosis, but instead it can prevent certain complications of tuberculosis in children like TB meningitis, disseminated TB infection, miliary TB, etc. So this is the reason why we are still giving BCG to the children. This is a live attenuated freeze-dried vaccine. Since this is a freeze-dried vaccine, this can withstand some amount of heat. In order to reconstitute this BCG vaccine and make it into liquid form, we add normal saline into it. The strain used in BCG vaccine is Danish 1331. The dose of BCG vaccine is 0.1 or 0.05 ml. That is, if the age of the child is less than 1 month, since they have got delicate skin, only 0.05 ml is given. If the age of the child is more than 1 month, 0.1 ml of BCG is given. This is given at left upper arm at the insertion of deltoid intradermally. So when we give intradermal injection, we need to make sure that the bevel of the needle should be always facing upwards. After we give BCG vaccine, the site of injection will slowly ulcerate and heal with time. Care should be taken to make sure that this BCG vaccine is given intradermally, because if it is not given as intradermally, this will lead to adverse reactions which include pain at the site of injection, BCG lymphadenitis, BCG osteitis, etc. Contraindication to BCG vaccine include anaphylaxis reaction. Any patient with immunosuppressive state, that is HIV positive patient, should also not take BCG vaccine, since this is a live attenuated vaccine. So this is all about tuberculosis treatment and control. If you have liked this video, kindly like and share this video. Please subscribe to our YouTube channel and hit the bell icon, and also like our Facebook page. Thank you very much.